Hello everybody, I'm Conrad Fischer. I'm the Associate Chief of Medicine for Education at SUNY Downstate School of Medicine in Brooklyn. I'm so happy to have you here with me again. I welcome you to cardiology and I wish you great success in your step 2. Remember that the basic format of all questions on USMLE starts out where the question writer says, I'm going to give you some history, I'm going to give you some physical examination, I'm going to give you some labs, or maybe not some labs, and from this position I'm going to ask you a couple of basic questions. I'm going to ask you, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial diagnostic test? What is the most accurate diagnostic test? What is the best initial therapy? Now, what we're going to do is we are going to learn how to think like a question writer. So that means from now on, you're going to think with these questions in your mind. What's the most likely diagnosis? What's the best initial test? What's the most accurate test? What's the best initial therapy? And we're going to fit all the information in the world into your brain in this format. Now, the most common root question is, which of the following is the next best step in the management of this patient? Now, when it says the next best step in the management of this patient, that could be either a test or a treatment. A test or a treatment. Did you know that the most important thing that you come to learn in USMLE preparation is the order in which to do things? I have heard about the tests and the treatments, but what is the order in which to do things? That's the main thing that we come to learn here now. Now, when you're applying for your EROS application, applying for your residency, your whole life is going to get reduced down to about 3 simple facts. What medical school did you go to? What are the scores? If you're a U.S. graduate, what does your dean's letter and your transcript show? And if you're an international graduate, what's your visa? All the other things don't get you that interview. Personal statements, letters of recommendation, pictures, no. Schools, scores, transcript. Schools, scores, dean's letter, or visa. So that means thinking like this is the direct effect on how many interviews you're going to get. So therefore, USMLE preparation, welcome to cardiology, study with the questions in your mind. What's the best initial test? What's the most accurate test? What's the best initial therapy? What's the next best step in the management of this patient? What's the next best step What is the next best step in the management of this patient? Let's look at some cardiology. Well, let's take a look at some of the aspects of chest pain here. Now, the first thing to do is to take a look at a person who's got some pain. Let's see. We have a 48-year-old woman who comes to the office, and this 48-year-old woman comes to the office, and she's got off and on again chest pain for the last few weeks. Sometimes it's with exertion, sometimes it's not with exertion. Sometimes it's with exertion, and sometimes it's not with exertion. So let's look at the qualities of these pain. Now the thing is that this person's pain, let's look here. He could be benign, could be life-threatening. Well, that's not a very specific statement, can't help us. The question is, how do we determine whether it's life-threatening or not? Well, the thing is, what is the most common common reason to have chest pain when you have a woman with no past medical history? What is the most common risk factor for coronary artery disease? Hypertension. Which of the following is the single worst risk factor? Diabetes. Correcting which of the following results in the greatest immediate improvement? Stopping smoking. Stopping smoking. She doesn't have diabetes, doesn't have hypertension, doesn't have hyperlipidemia. And remember, for it to count as a family history, mom and dad have to have their coronary disease young. Dad under 55, mom under 65, dad under 55, and mom under 65. Young has to be in their 50s and early 60s. She has no past medical history. Now you see this slide here where it says, well, exclude the most serious thing first? Well, there's 2 types of questions. The first question is, you have a 48-year-old woman with no past medical history who's got off and on substernal chest pain for the last couple of weeks, with exertion, not with exertion. What is the most likely etiology of somebody who's got discomfort there as a woman? She's not young, but then again, she's not old either. During 40 years of the Framingham study in Massachusetts, in 40 years they didn't have a single myocardial infarction in a menstruating female. Menstruating female. The menstruation is like perfume that lasts for 10 years. Perfumes those coronaries, keeps them fresh. Not a single myocardial infarction in a menstruating woman. So therefore, when you have this woman here with off and on pain and no risk factors, the likelihood of this being ischemic pain statistically is remotely small. So we have two questions. What is the most likely diagnosis? What is the most likely diagnosis? Substernal chest pain, off and on, atypical. Throw in a little nausea, a little GI complaint. Reflux. Reflux, reflux, reflux. Well, the most likely diagnosis may be reflux, but the best initial step is still an EKG. The best initial test is still an EKG. Now, the history of the chest pain is much more important than the physical. History is much more important. In other words, if you tell me that this is, whoa my gosh, look at this 75-year-old guy who's got exertional chest pain. Exertion plus pain, chest pain, I don't care what he's got physical exam findings. He's got ischemic disease. He's going to die of a heart attack. Old guy with exertional chest pain, ischemia. Physical examination doesn't show that much on a person with a myocardial infarction. What is the most common exam to be found? Not the most common abnormality, the most common examination to be found. Normal. Did you know that most people having a heart attack, a myocardial infarction? Do you know most of them have a normal physical? Most of them have a normal physical. You could have RALS if you have LV dysfunction. You could have JVD if you have left ventricular dysfunction. You could have an S3 or an S4, LV dysfunction, ischemia. But the most common is normal. What could you find? It's one thing. What's the most common is normal. Let's see. The first thing in the history is what is the duration of pain. If the pain lasts for a second, a needle for a second, not ischemia. A second of pain, 2 seconds of pain is not ischemia. Ischemic pain doesn't last for a second. On the other hand, ischemic pain also doesn't last for hours and hours and hours either. Ischemic pain is 10 minutes, 20 minutes, 30 minutes. If it's a second or if it's hours and days, it's not ischemic pain. The quality. Let's see. First of all, duration, not ischemic, seconds or days. The quality, ischemic pain. The ischemic pain is dull, sore, squeezing. In other words, ischemic pain is like you going to the gym. If you'd ever get to the gym, lifting weights, pumping, and ooh, I'm sore. That hurts. It's sore like a muscle. Ischemic pain, ow, ooh, who hit me? It was me. Ooh, sore. That's ischemic pain. It's a muscle that's sore. Damn, that hurts. Because the muscle, it's ischemic. Sharp, bing, no. Knife, bing, knife-like. Point-like, knife-like. No. Not ischemic. Okay, dull, sore. If they say point-like, if you say to the patient, can you point with your finger exactly on the one point where the pain is, and the guy goes, yeah, it's exactly there. Pointing with a finger, 95% of the time it's not ischemic. Ischemic pain can't be localized to one itty-bitty point. It's sore, it's substernal. Location. Did you know that 95% of ischemic pain is substernal in location? Right-sided pain, not ischemic 95% of the time. Left-sided pain, not ischemic either. Ischemic pain is there in the center. Right-sided pain for sure is not ischemic. Left-sided mostly is not ischemic. Guy says it hurts me there, it's not ischemic 90% of the time. Not ischemic 90% of the time. Ischemic pain lasts for 10, 20, 30 minutes. Ischemic pain is sore or dull or squeezing. Ischemic pain is substernal. Ischemic pain can go to the neck, but the absence of radiation means nothing. Ischemic pain can go to the neck, into the arm, to the neck, into the arm, neck, into the arm, neck, in the arm. Frequency. Ischemic pain can come with exertion, every once in a while with exertion. So alleviating factors means this. Exertional, relieved by rest. That is the definition of angina. Angina comes from the Latin word angere, to strangle. To strangle. My left ventricle is being strangled. Left ventricle is being strangled. So therefore, left ventricle is being strangled, and what ends up happening is that when you have ischemic pain is relieved by rest. relieved by rest. So chest pain that is on exertion, relieved by rest, is the very definition of angina. Now, a person who has associated symptoms, this is the weakest one. It belongs down at the end. See, it's at the bottom there? That associated symptoms is the weakest one. Why? Anything can make you short of breath. Anything can make you sweaty. Anything can make you short of breath and give you a sense of impending doom. They all can make you short of breath and give you a sense of impending doom, or make you sweaty or short of breath. That doesn't help very much. Now, remember here that angina pain is squeezing, tight, heavy, pressure, sore. These are very good words. These are very good words to remember. I mean, they're very bad words to have, but they're very good words to remember. These are very good. Hey, how does it feel? What does it feel like? Can you compare it? Shall I compare thee to a summer's day? Oh, no, I will compare thee to an elephant sitting on my chest. Shall I compare thee to an elephant sitting on your chest? Do you feel like there's a belt around my chest? Now, you have to be careful about what people are saying, because to see what they're really saying. I saw a guy the other day in the emergency room, and the guy goes, yeah, doc, I'm having terrible chest pain. It feels just like a knife stuck in my chest. And all the medical students came by and they said, you know what, Dr. Fischer, this man's chest pain can't be cardiac in nature, because you told us that knife-like, it cannot be cardiac. I said, you know what, this guy is an exception. I think this guy actually does have a cardiac problem. Dr. Fischer, you said if it's point like a knife, that it's not cardiac. But he's a little bit of an exception, is an exception. Well, what do you mean? Well, if you look at the guy, you'll actually notice that there is a knife stuck in his chest. So it's in his heart. So when the guy says, I have pain that's like a knife in my chest, you should make sure, in fact, that there is no knife in his chest. Other than that, knife-like, not ischemic in nature, tight, heavy, pressure, sore, dull. Tight, heavy, pressure, sore, dull. Squeezing. All evil, all evil. Now, the inferior wall myocardial infarction. The inferior wall infarction, the heart is pressing on the diaphragm. In other words, if this is the chest, and this is the heart inside the chest, the inferior wall is in fact on top of the diaphragm. So the inferior wall is, in fact, on top of that diaphragm. So when the inferior wall is on top of that diaphragm, it ends up causing irritation that can cause diarrhea. It can cause bradycardia. Why? Because there's a vagally mediated reflex. It irritates the diaphragm, it runs up in the vagus, and it causes a slowing of the heart rate. Hypotension, sweaty, shaky, bradycardia. In the past, that used to have a proper name to it. It was called a Jarisch-Bezold reflex. The Jarisch-Bezold reflex is a term applied to the inferior wall inflaming the pericardium, causing you to have vagal tone. The vagus dilates blood vessels. The vagus slows the heart rate. The vagus, because the dilated blood vessels and slowed heart rate, causes lightheadedness. That's inferior wall irritating my diaphragm. Remember, ischemic pain is not sharp or knife-like. And the other thing is, you see this reproduced on palpation? Ischemic pain does not associated with tenderness. If there's tenderness, not ischemic. If it changes with bodily position, it's not ischemic. If it changes with respiration, not ischemic. Ischemic pain is not positional, pleuritic, or tender. Positional, pleuritic, or tender. Ischemic pain is not positional, pleuritic, or tender. It's not positional, pleuritic, or tender. And it's not reproduced on palpation. Now, the pain generally lasts, if it's ischemic, for 20 or 30 minutes. But this thing, look at this. It says relieved by nitroglycerin. Relieved by nitroglycerin. Spasm is relieved by nitroglycerin. That is why here, spasm relieved by nitroglycerin, reflux worsened by nitroglycerin. That's because it opens up the sphincter and more acid comes out. This is why this response to therapy is a very poor way of making a diagnosis. The response to therapy is a very poor way to make a diagnosis. We're going to have to send you to a 12-step group. Hello, my name is Conrad. I admit I am powerless to seeing a response to specific therapy. Came to believe a power greater than myself could save me from diagnosing things with a response to specific therapy. We're going to have to send you to a 12-step group for a response to specific therapy. Okay? You can't use the response to specific therapy to making a diagnosis. There's about 3 exceptions. Opiates and Narcan. Diagnostic and therapeutic. Opiates and Narcan. Esophageal candidiasis and fluconazole. Esophageal candidiasis and fluconazole. Esophageal candidiasis, fluconazole. You can use the response to therapy. And CNS toxo. Narcan, naloxone and opiates, toxomeds, and fluconazole for esophageal candidiasis. Other than that, you will not use the response to specific therapy to make a diagnosis. Now, looking at the physical, what we find out is, you see this sweating and shortness of breath? This is unfortunately completely non-specific. Anything can make you sweat and have shortness of breath. It's too non-specific to be useful. It's evil, but it's too non-specific to be useful to say you're short of breath and you're tachycardic. Now, the thing that would be useful in the physical exam, would be useful in the physical exam is the fact that if you have a difference in blood pressure between your arms, that is indicative of aortic dissection, and that is useful. Now, remember that palpating the pain, the chest pain, means not ischemic in nature. Now, the murmurs and auscultation. Remember that the most common physical finding of the heart in a myocardial infarction, the most common physical finding of a myocardial infarction, the most common physical finding is nothing. Is nothing. Let's look at our first line here. Wide split of S2. Wide split of S2. Normally, an S2 is divided into an A2 and a P2. A2, P2, A2, P2, A2, P2. Aortic valve, pulmonic valve. Aortic valve, pulmonic valve. Aortic valve, pulmonic valve. A2, P2. If you have a delay to the closure of the pulmonic valve, right bundle branch block, it gets wide. Pulmonary hypertension, it gets wide. Pulmonic stenosis, it gets wide. Right ventricular hypertrophy, it gets wide. If you have it where the P2 is now coming before the A2, that's called a paradoxical. And a paradoxical split of S2 where it should be A2, P2, aortic, pulmonic, aortic, pulmonic. Why is it now pulmonic, aortic? Well, because something has slowed the contraction of the left ventricle. Something has slowed the contraction of the left ventricle. If right bundle slows the contraction of the right ventricle, that means a left bundle branch block slows the contraction of the left ventricle. That means hypertension slows the contraction of the left ventricle. That means aortic stenosis, left ventricular hypertrophy. Oh, yes. Splitting. Splitting is very nonspecific. And what's the only thing that gives you a fixed split of S2? A fixed split of S2. A fixed split of S2 is atrial septal defect. Now, paradoxical split, wide split, S4 gallop. S4 gallop. An S4 gallop is a sign of left ventricular hypertrophy. An S4 gallop is a sign of left ventricular hypertrophy. An S4 gallop is a sign of left ventricular hypertrophy. It's the sign of atrial systole into a stiff or non-compliant left ventricle. It's a sign of atrial systole. Normally the atrium should contract and blood should go forward freely into the left ventricle. The left atrium should contract and blood should go forward to the left ventricle. But what happens when the left ventricle is hypertrophic and stiff? Now the atrium contracts and the blood hits with a bang. The atrium contracts and the blood hits with a bang. Left ventricular hypertrophy. S4 gallop. The question says, what will you do differently based on the presence of this finding? Or the question can say, a person is showing up with hypertension for the last 20 years. Which of the following physical findings is most likely to be found in this patient? S4. A person comes with hypertension for 20 years. Which of the following physical findings is most likely to be found in this patient? An S4. What will you do differently based on the presence of the S4? Nothing. Why? Well, you were going to treat the hypertension anyway, weren't you? You were going to give a diuretic and a beta blocker anyway, weren't you? So you're not doing anything different. S4, what do I do differently? Nothing. S4, ischemic myocardium is stiff. Ischemic myocardium is inflexible. It's a sign of illness to be inflexible and rigid. It's a sign of intelligence to be flexible. Flexibility is a sign of intelligence. S3 gallop. You have the rapid filling of the ventricle. S3 gallop. S3 gallop. Evil. S3 gallop, increased therapy. S3 gallop, add a diuretic. S3 gallop, fluid overload. S3 gallop, splashy, splashy. S3 gallop, splashy, splashy. Normally blood should go from the left atrium into the left ventricle, and you shouldn't hear it that much. Oh, very quiet. But what if you are fluid overloaded? Fluid overloaded, man, too much splashing in. Splash! That's an S3 gallop. That's an S3 gallop. Splash! S3 gallop. S3 gallop. Ooh, I better get a little diuretic. Ooh, diuretic. ACE inhibitor. Diuretic. Feel much better. S3 gallop. Splash. Okay? S3 gallop. Need more therapy. S3 gallop. Make me sick. S3 gallop. Need meds quick. S3 gallop. Can't let them go home. S3 gallop. You're going to die. S3 gallop. More diuretics, more ACE inhibitors, more beta blockers. S3 gallop, acute pulmonary edema. S4 gallop, whatever, stiff ventricle, relax, baby, it takes a beta blocker. S3 gallop, evil. Can't let people go home. Can't let people go home. Can't let people go home with that. Now, the worst things that can happen to you with a myocardial infarction, of course, is death. But how do you get to that death? The valve sheet rupture. I have aortic regurg. The valve sheet ruptured. I have a mitral regurgitation. The papillary muscle is ruptured. I got to go to the operating room. Got to go to the operating room. So that's it for physical findings. What I want to repeat is the most common physical finding in a myocardial infarction is a normal physical exam. When there is an abnormality, remember, tenderness is huge. It's not ischemic. Which of the following is the most likely diagnosis? Tender, not ischemic. S3 means more medications. S4 does not. The test. What's the first initial test? And the answer is, oh, look at the drama of that EKG coming across. Look at the drama of that EKG. The EKG, even if you think it's not cardiac, do the EKG first. Do the EKG, okay? If you have a person who's got ST segment elevation, all you need is chest pain and ST elevation, and that's all you need to indicate therapy. Chest pain and ST elevation. Now, on the EKG, which is the best initial test, the first thing to do is to see about ST elevation or ST depression. ST elevation and ST depression. Now, what we found out about people who have heart conditions to the point of causing ischemia and pain is that our ability to be able to tell the difference by physical findings is zero. You can't use, there's nothing on physical findings that can tell you this person's having an infarction and this one's just having ischemia. And you might be saying, oh, but Conrad, didn't you just tell me that tenderness means not ischemic? Yes, tenderness means not ischemic. But of the people who are not tender, not positional, not pleuritic, there is ischemic pain. How do I tell whether that person is having a myocardial infarction, angina, unstable angina? How do I tell these two things apart? The answer is there is nothing on physical that can tell me. There are things on physical to tell me it's not coronary disease, positional pleuritic or tender. But once I think that there's coronary disease, there's nothing on physical that would distinguish these. I can't tell these apart, unstable angina. So therefore, since I don't know who's going to have unstable angina and who's going to have an infarction, I can't tell until I get the troponins and the CKMBs. And how long does it take for troponins and CKMBs to elevate? How long is that going to take to begin to elevate? 4 hours, 3 to 4 hours. It's going to take 3 to 4 hours. It's going to take 3 to 4 hours. And it doesn't reach its peak for 12. So therefore, I might not be able to tell for 12 hours. Well, up to how many hours after the onset of chest pain are thrombolytics indicated for? 12 hours. Well, if I can't tell it's ischemic for 12 hours for sure, I sure don't want my thrombolytic indication to be something that I can't use for 12 hours. I need to be able to tell now. This term, unstable angina versus MI, is not as accurate because this person might have an MI 12 hours from now when the troponins come back. So altogether, both of these things together are called acute coronary syndromes. An acute coronary syndrome means that you have chest pain that's ischemic, and I don't know if you're going to have an infarction. An acute coronary syndrome. So if we see ST segment elevation in 2 leads, that's enough to indicate therapy. If we see ST segment depression, T wave inversion, normal, but the story is like ischemia, we have divided this up into ST segment elevation and non-ST segment elevation. So I could say ST depression, I could say normal, I could say T wave inversion, but it means there's not an ST segment elevation. ST elevation and non-ST segment elevation. Acute coronary syndromes. You don't know which is which until you have the troponin and the CPK. You're not going to be able to tell. Troponins only, and remember, troponin and CKMBs only begin to elevate at 4 hours. They may not actually become positive for 12 to 18. So I use the ST elevation. See the ST elevation? I use the ST elevation to answer the question, thrombolytics yes, thrombolytics no, thrombolytics yes, thrombolytics no, ST elevation, thrombolytics yes, TPA is better than the rest, angioplasty. And the other word for angioplasty is percutaneous coronary intervention. Oh, not a plasty, an intervention? Yes, an intervention. Yes, an intervention. Oh, an intervention. Yes, an intervention. A balloon or some other form of intervention. If there's ST depression or T wave inversion, then it's no TPA. It's no TPA. Now, diagnostic testing. I can't tell till later on. Let's see here. What are we looking for here? We're looking at, my goodness, it's a normal EKG. See, that's a P wave. QRS, T, P, QRS, T, P, QRS, T, P. Indicates atrial depolarization. QRS, ventricular depolarization. T wave, ventricular repolarization. The P wave, the QRS, and the T. That's normal. What's the heart rate here? 300, 150, 100, 75. If there's 1 box away, 300. 2 boxes, 150. 3 boxes, 100. 4 boxes, 75. 60. A normal heart rate is 60 to 100. A normal heart rate is 60 to 100. It's a normal EKG. It's a normal EKG. P wave, atrial depolarization. QRS, ventricular depolarization. T wave, ventricular repolarization. P, QRS, T. Normal heart rate is 60 to 100. If the next beat was here, that'd be 300, 150, 100, 75, 60. Normal EKG. And P, QRS, and T. That's a normal complex. How beautiful is that? Acute infarction? What's different? What's different here? Here, you see that? That's ST elevation. See that? That's ST elevation. That's the baseline. That's the baseline. See that? That's the baseline. That's elevated. That's the baseline. That's the baseline. That's elevated. That's the baseline. That's elevated. That's the baseline. That's elevated. The ST segment is elevated. It leads 2, 3, AVF. 2, 3, and AVF. Let's look at that for a second. Leads 2, 3, and AVF. If we look at our hexaxial grid, we see that AVF is down here. Lead 2 is over here, and lead 3 is over here. 60 degrees, 90 degrees, 120 degrees. That means that the EKG leads are like cameras viewing the heart. And what we see here is that these EKG leads are looking at the bottom of the heart. 2, 3, AVF, the inferior leads, looking up at the bottom of the heart. 2, 3, AVF, looking up. All right. See, the baseline is here. That's elevated. How much elevation do you need to be considered significant? How much elevation do you need to be considered significant? And the answer is 1 millimeter or more. 1 millimeter or more in 2 leads. 1 millimeter or more in 2 leads. 2 leads. ST, elevation, means thrombolytics angioplasty. Thrombolytics angioplasty. Now, let's look at our biomarkers. Troponins and CKMB are extremely specific to the heart. Troponins and CPKMB. See how it says it's present 4 hours after the onset, but it won't peak for 12 hours. Now, since it only lasts for 3 to 4 days, see how it says lasts for 3 to 4 days? Since it only lasts for 3 to 4 days, if they give you a question, they said, a guy had a myocardial infarction 4 days ago, and now he's developed new chest pain. What test would you get first to see if he's having a new infarction? It's first the EKG. What test would you get next to see if he's having an infarction? CKMB. What's the biomarker for reinfarction? CKMB. Why? Because troponins last 1 to 2 weeks. Troponins last 2 weeks. So if I have new chest pain in 5 days and my troponin is still up, it was from my first MI. If I have new chest pain in a week at 5 days and the troponin is still up, it was the first MI. So CKMBs go up fast, down fast. So for reinfarction, CKMBs. See reinfarction? CKMBs. Now, troponins here, also, even though you get isoenzymes, it's not as important as the fact of just saying a high CKMB is sensitive and specific. A high CKMB is sensitive and specific. Why did we not use CKMBs or troponins to determine thrombolytics versus no thrombolytics? Because thrombolytics are only indicated for how long after the onset of chest pain? Less than 12 hours. So if the CKMB is not up, you can't have the CKMB be your measure of whether to give thrombolytics. Thrombolytics I need to know now. Now, although there's mortality benefit for up to 12 hours with thrombolytics, once somebody comes to the hospital door and says, I have chest pain, what is the federal standard for how long it's supposed to be before you get those thrombolytics into the person's vein? How long is it supposed to be? Hi, I have chest pain. When am I supposed to get my thrombolytics? 30 minutes. 30 minutes. It's kind of like this. When you call up Domino's Pizza, they don't say, we'll deliver your pizza based on how long you've been hungry for. They say, once you notify us that you're hungry and you order, we have to give it to you in 30 minutes. So here, it's the same thing. Chest pain may be up to 12 hours, but once you're in the door and say, hi, I have chest pain, you got to get those thrombolytics in 30 minutes. CKMBs and troponins. The major issue is that troponin is extremely specific. Preferred is extremely specific, but it builds up in people who have renal failure. It builds up in people who have renal failure. Troponins build up in people who have renal failure. And here's the other thing is, it can remain elevated for weeks. That means if a week later you're having new chest pain, you can't use a troponin to tell you whether or not you have ischemia or not. The person has chest pain. Is it ischemic? Is it not? Costochondritis? GI. What is it? Is it pneumonia? A pneumothorax? A pulmonary embolus? What is it? Is it positional pleuritic or tender? Positional pleuritic or tender? Let's look at the differential diagnosis of chest pain. So when you have a person who has chest pain, the first thing is, oh, look at this. Chest wall palpation. Not ischemic. Reflux disease. If you have you have chest pain and it's not ischemic in nature, reflux disease. If you have chest pain, it's not ischemic in nature, what's the most common? GI things. If you have chest pain, it's not ischemic in nature, what is the most common etiology? GI things. What is the most common etiology of non-cardiac chest pain? GI things. Now, peptic ulcers have epigastric pain, but for every 100 people with epigastric pain, see the epigastric pain? What is the most common cause of epigastric pain for every 100 people with epigastric pain? Not ulcers, not gastritis, not pancreatitis, not cancer. It's non-ulcer dyspepsia. The most common etiology of epigastric pain is, in fact, non-ulcer dyspepsia. Non-ulcer dyspepsia. Peptic ulcer gives the epigastric pain. Now, you can't tell a whole lot until you get some tests. Remember that myocardial infarction pain is squeezing tight. The aortic stenosis. What is the most common presentation with aortic stenosis? Aortic stenosis has 3 different presentations. Syncope, CHF, and angina. Syncope, CHF, and angina. Syncope, CHF, and angina. What is the most common of those presentations for aortic stenosis? It is angina. It is angina. It is angina. Next thing is, what is the worst prognosis for aortic stenosis? The congestive failure. The most common? Angina. The worst? Congestive failure. Myocarditis, this next one, myocarditis is extremely variable. Asymptomatic inflammation of the ventricular tissue, or maybe a little shortness of breath, or maybe some vague dull pain, or maybe pulmonary edema. Myocarditis has the most variable presentation because it could be asymptomatic, mild exertional shortness of breath. Myocarditis can be anything from asymptomatic to pulmonary edema and chest pain and death. Now, pericarditis is unique. That's one that you really could be asked because it has a unique presentation. Pericarditis is the only form of chest pain that is both pleuritic, changes with respiration, and positional. It gets better when you lean forward and worse when you lean back. Better when you lean forward and worse when you lean back. Ready? Carditis. Because when I lean back, it stretches my pericardium. When I lean back, it stretches my pericardium. It's positional and pleuritic. It's the only form of the chest pain. Pericarditis. Dissection. I like that. Sharpen. That word is tearing, not tearing. You'll be tearing, they'll be tearing. They're spelled the same too. They're tearing and you're tearing. They're tearing and tearing. Yes, but somebody's having excruciating chest pain and you go, excuse me, would you call that more of a ripping, a tearing, or sort of like your soul being transposed and avulsed from your body? I mean, is that sort of a soul-ripping pain or just an ordinary tearing pain? Well, this is very hard, very subjective. So it is better to say, well, what is truly unique about aortic dissection? In between the scapula. In between the scapula. In between the scapula. To the back, in between the scapula. Now, if some of these things seem overlapping, you know why it seems like a lot of the etiologies of chest pain have overlap in their presentation? You know why it seems like there's so much overlap? It's because, it's because there's a lot of overlap. You know how it seems difficult to tell them apart from the presentation? That would be because it's difficult to tell them apart from the presentation. You know, that's why myocarditis is a hard one to ask you as a diagnosis. Because you give me any presentation, the answer is, could be. But if I give you positional and pleuritic, no, pericarditis. Through to the scapula, up, aortic dissection. Aortic dissection. Chest wall tenderness, costochondritis. Costochondritis. Mitral valve prolapse. Transient pain, but not only just transient pain, it's atypical pain. In other words, it's not on exertion. Mitral valve prolapse, not on exertion. Maybe it's on exertion, maybe it's with rest, maybe it's both. Maybe it's on exertion, maybe it's with rest, whether it's both. Maybe it's with exertion, maybe it's at rest, maybe it's at both. Mitral valve prolapse, atypical pain in a young female. Mitral valve prolapse. Mitral valve prolapse gives you atypical, just a pain. It's also associated with palpitations and panic attack. Mitral valve prolapse, pain, palpitation, panic. Pain, palpitation, panic, prolapse. By the way, why do you get pain with mitral valve prolapse? You don't know? Come on. Come on, baby. Come closer to the screen. Come here. Come closer to the screen. Why do you have chest pain with mitral valve prolapse? You don't know? Oh. Well, you know, I don't know either. I thought you might know, because I don't know. I have no idea. Now, what's the difference between my level of ignorance and your level of ignorance? You have superficial ignorance. I have deep ignorance. You don't know, and you think someone knows. I don't know, and nobody knows. Nobody knows. So that's the difference. The point that becoming a specialist is to deepen your ignorance. Why do you get chest pain, palpitations with prolapse? Unknown. Unknown. Nobody knows. The other things is, remember, pulmonary embolisms are very hard to tell apart because they all present with shortness of breath. Tachypnea is another way of saying shortness of breath. Shortness of breath and tachypnea. I never said shortness of breath that made you breathe slower. They all make you breathe faster. Hemoptysis. What's the most common cause of hemoptysis in the United States? Is it cancer? Is it TB? No, it's bronchitis. Anything that makes your cough causes hemoptysis. Anything. Hemoptysis just means you're coughing. You ready? Hemoptysis. Look, blood. Hemoptysis. Look, there's blood. What causes a Mallory Weiss? Mallory Weiss. Anything that makes your vomit causes a Mallory Weiss. Mallory Weiss. Hemoptysis. Yeah, well, you know, if you cut me, do I not bleed? The quality of mercy is not strained. It droppeth as a gentle rain from heaven upon the ground beneath. It is mightiest in the mighty. If you cough, do you not have bleeding? If you retch, oh, you have bleeding. Mallory Weiss hemoptysis, same idea, non-specific. Pneumothorax looks just like a pulmonary embolus. If they don't give you tracheal deviation, decreased breath sounds, you won't be able to tell a pneumothorax from pulmonary embolus until after you get the chest X-ray, chest X-ray. Specific diseases resulting in chest pain. The dissection, remember, radiating to the back, sharp tearing, radiating to the back. If it goes through one of your arteries on one side, you can lose a pulse or have a difference in blood pressure between the left and the right if you dissect through one of the arteries. Now, this is a very good thing here. Aortic dissection, wide mediastinum. Aortic dissection, it says, which of the following is the best initial test for aortic dissection? Aortic dissection, okay? Aortic suspected dissection, the suspected dissection. The best initial test is a chest X-ray, looking for a widened mediastinum. Now, after the chest X-ray, you can do a transesophageal echo, you could do a CT angiogram, and you can do a magnetic resonance angiogram. All three of these are about equal. They all achieve 90 to 95% sensitivity. Wide mediastinum chest X-ray is first. Then either transesophageal echo, a CT angio, or an MRA after that. The single most accurate test is a regular angiogram, putting a catheter into the heart. Now, you could have an infarction and a dissection if you go through the coronaries. That's bad luck. Remember that between these three modalities, these are all about the same. They're all about the same. Now, aortic dissection is showing you here, well, it looks like an arrow, that the aorta goes to the back here, along the spine. Along the spine. Now you know why when there's dissection, people get back pain. When there's dissection, it goes to the scapula. Now you know when there's dissection, it goes to the scapula. Pulmonary emboli. Well, shortness of breath, and this again is somewhat non-specific. Pulmonary emboli give you hypoxia. Congestive failure gives you hypoxia. Lots of things can give you hypoxia. The things that give you pleuritic pain, though, that also is non-specific. Let's look at pleuritic pain. Pleuritic pain is caused by a PE. Pleuritic pain can be caused by a pneumonia. Pleuritic pain can be caused by pericarditis. Pleuritic pain can be caused by a pulmonary embolus, a pneumothorax, by pleuritis. Anything here. Wow, how convenient that all the things with pleuritic pain begin with a P. Isn't that convenient? That's non-specific. See, spiral CT is the big question for pulmonary emboli. VQ scanning, or it says lung scanning here, VQ scanning. VQ scanning is the scan of choice in a pregnant woman. The most accurate is an angiogram. You won't do an angiogram, but it is the most accurate. Remember, pericarditis is often caused by a virus. Those viruses are not specifically diagnosed. We presume it's viral. Remember, the other part about pericarditis is the person will say it feels like they're being stabbed or cut. It's sharp like a knife, and better when you lean forward, it relieves stretch on the pericardium. Now, there's something we didn't say before, is that pericarditis, you are getting rubbed, a rub, okay? Like the man teaching about frauderism, and at the end of the lecture he said, how'd I do? Did it all rub off on you? So pericarditis, okay? Pericarditis is a person who should have a rub, but only in 20 to 30% of cases, okay? 20 to 30%. Most people don't have the rub. Now, the pericarditis, although there's diffuse ST segment elevation, what is the single most specific test for pericarditis? The single most specific finding on an EKG for pericarditis. Diffuse ST segment elevation. But what's the single most specific test for pericarditis? Is PR segment depression. PR segment depression. Although the CKMB is usually normal, it could be mildly elevated. And here's the pericarditis question. A guy comes to the emergency room, he's been seen a couple days ago, he had pleuritic pain that was positional in nature, there was ST elevation, he got put on ibuprofen, naproxen, and some form of nonsteroidal, and 1 day, 2 days later, he still feels bad, he still has pain. What would you do next in the management of this patient? 2 days later, he still has pain. What would you do next in the management of this patient? And the answer is, start steroids. The answer is, start steroids. The answer is, start steroids. He's on nonsteroidals, start steroids. Look at myocarditis. Very nonspecific. Very nonspecific. And South Americans with Chagas disease, exactly. And as soon as we change this from the USMLE to the BMLE, the Brazilian Medical Licensure Exam, then that'll be the most common answer. But when you see Chagas disease on this test, it's a wrong answer. Okay? All those flies die of like lung cancer and COPD from all the pollution in North America. They freeze up in the winter. So the insects don't make it up too well into New York. So Chagas disease, although it can cause myocarditis, is a wrong answer here. So non-specific findings with myocarditis. You see how it is? Vague, mild, CKB. Well, how are you going to make that diagnosis of myocarditis anyway? Biopsy. Excluding the other diseases and biopsy of the heart. Exclude the other diseases and biopsy of the heart. Well, a pneumothorax causes also abrupt this pneumothorax. Now, most pneumothoraces are not a tension pneumothorax. Most pneumothoraces are 10, 20, 30%. You can't really tell that they're a pneumothorax till after you get a chest x-ray. See, it can give abrupt, sharp pleuritic pain, but isn't that the same as pericarditis? Yeah, it is. Isn't that the same as pulmonary embolus? Yeah, it is. Breath sounds are absent only if it's a tension pneumothorax. You don't get absent unless it's a tension pneumothorax. Pleuritis, what is that? Well, that also, oh my God, look at this, what a shock. Sharp pain that gets worse with inspiration. That's what we said, pleuritic pain. So we're saying here again, they're all pleuritic pain. Now the difference is, which of these can give you a fever? See, a pneumonia can give you a fever and pericarditis can give you a fever. But then again, so can pneumothorax, pleuritis, and pulmonary embolus. Which of these can give you a fever? All of these can give you a fever. Which of these can give you a fever? All of these can give you. Which of these can give you a fever? All of these can give you a fever. They all can. So that doesn't help you tell you apart. Pleuritis is viral pleural infection. The pleura is inflamed. When it rubs up against the other pleura, it hurts. It's like esophageal candidiasis. You eat, you swallow, it rubs, it hurts. Non-steroidals. It's usually from an underlying lung infection, non-steroidals. Pneumothorax, you see this side of the lung there? That side of the lung should be over here. That side of the lung should be over here. That side of the lung should be over here, should be moved over. Now, that is the pneumothorax, telling you there's too much space there. This person has a picture of a chest tube deficiency.